Good afternoon, everybody. My name's Arnold, and my PhD topic is New Perspectives on Transplantation in the Treatments of Cancer and Diabetes. So I've graduated as a medical doctor as well as in biomedical sciences, and I'm currently a first-year PhD and master's student. This is my team, and our vision together is to offer the best medical or surgical options to cancer and diabetic patients and improve the level of healthcare offered in Eastern Europe and more. And our mission to achieve that is by learning from the very best in the field, finding knowledge gaps, and improving current standards and policies for the treatments of cancer and diabetes. So we've currently got two projects. So without further ado, we'll start with the first one, which is called Comparing the Effect of Pancreas and Islet Transplantation to Insulin Therapies on Glucose Metabolism in Patients with Type 1 Diabetes Undergoing Renal Transplantation. This is a systematic review and meta-analysis. So a little bit of background. Well, diabetes actually accounts for around 45% of chronic kidney diseases. In some countries, 40% of patients with diabetes are actually listed for renal transplantation. The only cures actually accepted for type 1 diabetes would be pancreas or islet transplantation. Interestingly, up to 96% of pancreas transplants are either done simultaneously with renal transplantation or after. Pharmacy and technology are advancing constantly, and they deserve to be compared to these established transplantation methods. In other words, we want to look at the insulin therapies, and with good reason, because as you can see on the figure, diabetes is set to grow exponentially in the next 20 years or so. So what's our aim? Well, looking at these figures, we just want to look at these three interventions when combined with renal transplantation. The first figure is a little illustration of pancreas transplantation, the second a part of islet transplantation, and the third shows a relatively modern version of insulin therapy, but we're going to look at any type. So what's our aim? Well, we want to determine which therapies can improve glucose metabolism and other outcomes. So quite simply, the population is type 1 diabetes patients undergoing renal transplantation, and our intervention and comparative will be pancreas transplantation, islet transplantation, or insulin therapy. Our primary outcome is glucose metabolism in the form of HbA1c, but there are others too. And we have multiple secondary outcomes, such as renal function, cardiovascular risk assessment scores, overall survival, and graft survival. So the clinical question: is insulin therapy combined with renal transplant superior to double transplantation in patients with type 1 diabetes? Well, our hypothesis is that less invasive methods are not inferior to invasive methods, or at least will not be in the near future. So what's the clinical implication to this? Well, the level of surgical need for type 1 diabetes patients may decline in the future. So, our search key and flowchart. Well, our first domain referred to the diabetes in the population, the second domain referred to the renal transplantation, and the third to the accompanying therapies. We started with over 13,000 articles, and we're now down to 275. So we have some final results that we have submitted, and we'll present these at the European Pancreatic Club meeting. So this first figure shows comparative studies between simultaneous pancreas kidney transplantation versus kidney transplantation alone, although it's never alone because it's together with insulin therapy. And these figures show that simultaneous pancreas kidney transplant decreases HbA1c levels by 2.16% more compared to kidney transplantation alone after 12 months of follow-up. Now, you can see there's a little bit of heterogeneity, but I'm going to address that in the next figure because it's even higher. It's actually a good thing. So this figure shows single-arm studies, simultaneous pancreas kidney transplant at baseline versus 12 months after the double transplantation. And what do we see? Well, we see that it decreases HbA1c levels by 2.95% after 12 months compared to baseline. Now, the very interesting fact about this study, and I'm just about to address the heterogeneity, is the fact that, okay, there are different amount of patients in each study, but the main thing is, if you look at the pre-mean, which is the baseline value, you see that they vary massively, so above 10 to even 6. Now, the interesting thing is that after 12 months, they all fall relatively within the same range, which is a really interesting finding. So, our first project. Well, we've extracted all of the data. The first round of data is handed over to the statisticians. We've handed over 42 tables, and I'm currently in the process of cleaning the graphical or Kaplan-Meier data before I send that as well. So, we've come quite a long way, and now onto the second project, which is comparing liver transplantation to systemic and regional therapies in unresectable hepatic malignancies. So, a little bit of background on this topic. Well, the liver is the most common site for metastasis. It's actually more common than primary hepatic cancers. Up to 50% of colorectal cancers end up in colorectal liver metastases. The liver is the most common location for metastasis for most cancers, actually. Now, the good thing is that up to 80% of metastases are confined to the liver. The bad thing is that the majority are considered unresectable. So liver transplantation is an option for unresectable primary or metastatic cancers in the liver, contrary to what we might have learned in medical school. So sticking to these figures, which basically just show liver transplantation versus established therapies such as radiotherapy or chemotherapy, I want to say that very recent studies, because it's a hot topic right now, show that these patients could be very good candidates for liver transplantation. So we want to assess the effectiveness of liver transplantation in different oncological diseases. So, population, patients with unresectable liver metastasis, intervention will be liver transplantation, and we'll compare that to established therapies. Our outcome will be overall survival. So, is liver transplantation the best option to treat patients with unresectable cancer? Our hypothesis is that it is the best option for treating some forms of unresectable liver cancer. Now, what's the clinical implications of this? Well, it's a big one, because more patients with unresectable liver cancers could be placed on transplant waiting lists, ultimately giving them a second chance at life. So, this is our preliminary search key. The first domain refers to the liver neoplasm, the second to the transplantation, the third to the comparator therapies, and the fourth domain will be the outcome. There are a few studies registered on Prospera at the moment. However, they're not designed in a way that we would like to do so. So, we have multiple key articles. We haven't added all of them, but we have added 2 forms of key articles. So, as you can see on the top, the first are based on colorectal liver metastasis, and the second on primary hepatic cancers. The topic is feasible, but it's currently on hold due to the size of the first project. So, in summary, our first project we hope to submit later this summer, and our second project realistically early next year. I'd like to finish on a quote, which is very close to my heart. A little science distances you from God, but a lot of science brings you closer to him. And that was said by Louis Pasteur. Thank you very much for your attention.
Do you think that there are enough donors to fulfill the studies?
The taboo topic of transplantation, donorship, no. There are not enough donors, but hopefully once policymakers look at these type of studies, they might think of ways of increasing the number of donors. So some countries actually automatically think of every person in the population as a donor unless they opt out before or their family disagrees at the moment of decease. However, we are far from that in this area of the world.
What is the estimated number needed to treat to be able to evaluate these data?
The estimated number of donors? Well, in terms of pancreas transplant or liver transplantation?
Each, both.
I don't think we're touching 10–20% yet. So.
I see. What do you think the post-transplantation immunosuppressive therapy might have on the results of these. You know, want to compare 3 different groups at least, and one of them wouldn't have immunosuppressive therapy.
So, in the context of the first project, we've actually looked at you know, every type of immunosuppression that's happened over the past you know, 30 years. There are clear differences. We couldn't pull them together for various reasons. There are clear favorites, but they've been established in therapy over time. These insulin therapies can obviously pose a threat to the success of the transplantation, or actually bring in other problems afterwards, because they are toxic at the end of the day. However, looking at the data in the first project, results are improving, and success rates are very, very high. You know, we're talking almost 100% after 1 and 5 years. In terms of the second project in the liver transplantation immunosuppression therapy, that doesn't show us actually that great data yet. But I think it will do very soon.
Are you planning to do a subgroup analysis with the liver malignancies in your second project, that metastasis and primary hepatic cancer, because this is absolutely different biological behaving tumors? So,
yeah.
I recommend you.
The answer is yeah. Like I said, looking at the key articles, I want to look at all of the colorectal liver metastasis. I want to look at the primary cancers too, as well as neuroendocrine tumors too, because they behave differently, and these patients might end up with you know, a different prognosis. And that's why in my hypothesis we stated that it may be the best option in some liver cancer.
That's because the metastasis is a stage 4 cancer,
yeah, absolutely.
so it's absolutely the prognosis is different.
So the good thing about the studies and why they are able to show such good results is because they follow this some criteria. So one might be the San Francisco criteria or the Milan criteria, which shows, in my opinion, it's a little bit more successful. So that would be the reason why these patients are actually surviving after the liver transplantation.